Good afternoon, everyone. Thank you for joining us at this session about the use of race in clinical algorithms. I am Dr. Michelle Albert. I am a professor of medicine at the University of California in San Francisco and the immediate past president of the American Heart Association. I want to welcome you to our panel discussion today, and I would encourage you to share in a discussion on social media and using the hashtags AHA23 and equity in equations. We are really looking forward to a robust discussion today. We have a terrific panel that I'm joined today by Dr. Tiffany Powell, who is from the NHLBI. We have Dr. Sadiya Khan from Northwestern University. We have Dr. Clyde Yancy from Northwestern University and Dr. Josef Coresh from Johns Hopkins School of Medicine. Dr. Coresh is voice may be a little bit down today, so please bear with us as he tries to answer questions. I'd also like to recognize Dr. Cindy Escobar Alvarez, who's the Program Director for Medical Research at the Doris Duke Foundation. The AHA has designed a 2-year scientific research strategy funded in part by the Doris Duke Foundation to study the complex issue of how race and ethnicity factors into clinical care, algorithms, and risk prediction tools. Just last month, the AHA announced a second round of grant opportunities as part of this strategy. So we are so glad you joined us, Sandy, here today. And I am grateful. I'll say that I just told Sandy that I was a previous Doris Duke awardee. So thanks and thanks and thanks again. So before we get started, I'd like to ground us in some information to contextualize the discussion that we'll be having here today. So many of you might be aware that in 2020, the American Heart Association put out a presidential advisory and laid out structural racism as a major cause of poor health and especially poor cardiovascular health and stroke. So we know that despite advances in cardiovascular disease prevention and treatment, that there are huge disparities that still exist related to race and ethnicity and cardiovascular outcomes. We know, for example, that Black and Hispanic persons are less likely to receive treatment for stroke complications. We know that Black and Hispanic persons with and without insurance are less likely to receive revascularization procedures for cardiovascular disease, such as coronary artery bypass grafting and percutaneous angiography. We also know that young Black adults have worsening outcomes during and after hospitalization for cardiovascular disease. And so we know that with these persistent disparities, these disparities have led to the research and the clinical and educational community, I would say, to rethink how race is used in clinical decision making and especially in our risk prediction tools. We know, for example, that race-corrected algorithms impact health equity, and patients have received differential care because of how race has been factored into guiding algorithms. It is important to include race and ethnicity in observational studies and epidemiology studies that seek to understand prevalence and incidence of disease. And I think that that still continues to be pretty important. But we all know that race is not a biological variable. And without understanding or paying attention to the underlying social determinants of health, such as the history of slavery and the continuing repercussions of slavery over time to current day, which has resulted in structural discrimination and toxic stress, leading to all sorts of outcomes, including cardiovascular outcomes, or what I would coin the biology of adversity. The use of race in clinical decision-making may perpetuate disparities in care. The use of race and ethnicity in research and patient care needs to be handled with attention, and I would say attention and intention, actually, to its purpose and potential pitfalls. With that, I would like to turn to now our panel to talk about how we bring these concepts into practice. Before we do that, I want to also ground this discussion in two major principles. The first major principle, I think, is the principle of anti-racism. And then the next principle is the principle around health equity. So let's turn to our panelists now. And our first overarching question is, what is the role of race in atherosclerotic cardiovascular disease risk and the extent of racial disparities? So I'm going to place the first question to Dr. Khan and ask Dr. Khan, how has race been used in the past? And I would like you to framework this answer by contextualizing the pool cohort equations and, of course, the prevent equations that you're such a part of. And I would say congratulations to you and your team and Dr. Coresh and others for the amazing work that you guys have put in to rethinking the formulation of risk for cardiovascular disease. So.
Thank you, Dr. Albert, and thank you all for attending this really important discussion. So when we think about ASCVD risk, and as Dr. Albert mentioned, we know that Black Americans have a much higher risk of ASCVD, but also of the preceding risk factors that go into risk prediction: hypertension, diabetes. So there's a higher prevalence of those risk factors. When we think about the current framework for risk prediction prior to PREVENT, the pooled cohort equations, which were developed in 2013, utilized Black and white adults from multiple cohorts to develop coefficients that were race and sex specific. So they specifically looked at just Black and white adults and developed equations that were useful for white Americans or Black Americans. I think this set up a really important framework whereby the intention was to consider race as a proxy for factors and lived experiences that could contribute to increased ASCVD risk. And this was an advance from the prior equations that had been developed in cohorts like Framingham that only had white adults. Since then, we know that we've come a long way in how we understand and contextualize race as a social construct. And the fact that including it in risk prediction might actually make it perceived that it is a biological predictor, which it's not, was a really important aspect of our discussion when we were considering whether or not race should be included in the PREVENT models. We know that there are differences in risk factors, but we don't want to incorporate race as a predictor. Rather, we wanted to focus on the importance of ensuring that the PREVENT equations would be generalizable to a diverse sample of adults, no matter what their race was. And so we tested it not just in 3 million people, but we also tested it in specific race subgroups and showed that the equations accurately and precisely predicted risk for a broad group of adults in the US. And really, I think that's important here, and being able to say that this is generalizable in a large population of adults.
Thank you. Could I do a follow-up question? What are some of the challenges, nonetheless, of the PREVENT risk equation?
Yeah, absolutely. I think, we've come a step forward in being able to say we now have equations that are broadly generalizable, and importantly, moving beyond having race dichotomized as Black Americans or white Americans and thinking more broadly. But there are still challenges, and I think one of these is the importance of thinking about how social determinants of health can be integrated into risk. If we think about the upstream factors that contribute to an influence risk, we haven't yet integrated all of these. One of the optional add-on models that we developed incorporates zip code level social deprivation index, getting at the fact that the place where you live, play, grow, influence your access to healthcare, your risk for disease, but that's still at an early stage. And so while it's a critical step forward, we think that there's a lot more that needs to be done in how we capture, harmonize, and address social determinants of health.
And certainly, as we know, that the American Heart Association is in full support of the strategy around CKM, which is cardio, kidney, metabolic risk. And in the work that you have done, that heart failure has been added. We have Dr. Yancy in the panel. Heart failure has been added as an outcome, and certainly GFR has also been added as a predictor as part of this modeling.
Yeah, and importantly, I know a lot of the work that the CKD Prognosis Consortium has done, led by Dr. Coresh, has been really emphasizing the importance of not just adding that EGFR, but incorporating a race-free EGFR into those prediction equations as well.
Thank you. Dr. Powell-Wiley, you have the next question. So we heard Dr. Khan talk about social determinants of health and the fact that in PREVENT, or the CKM equations, that social risk is an optional entity depending on whether it can be contextualized or used in a particular individual. Tell us how social determinants of health might be important as part of this assessment. I know that your life's work to date is related to social determinants of health.
So when we think about social determinants of health, we want to think of the multiple levels of factors that relate to where we live, work, play, and pray. And so these are factors related to the neighborhood environment in which one lives. That can be related to the physical environment, but also the social and cultural environment in which they live. We also need to think of factors related to the socioeconomic status that they have, the resources they have from an economic standpoint, and those relate not just to income and education, but also to housing and access to resources within their community. And then we want to think of some of those more psychosocial factors that relate to things such as depression, loneliness, factors that we know have an impact on cardiovascular disease, but health outcomes in general. And when we take into account these multiple levels of social determinants of health, we know that each of these play a role in the development of cardiovascular disease, as well as outcomes related to cardiovascular disease. And so it's been critical, and I think it really is a sea change in terms of risk prediction by including measures and utilizing measures like the Social Vulnerability Index as a part of the PREVENT model. And this really does take a step forward in utilizing measures that are racially patterned based on historic and contextual factors particularly within the United States.
Thanks, Dr. Powell-Wiley. Dr. Yancy, you have often said that we need to move from social determinants of health 1.0 to social determinants of health 2.0. Could you tell us what you mean by that?
Thanks very much, and I'm really delighted that you've taken such a leadership role in helping the American Heart Association articulate the importance of calibrating risk as a function of communities and circumstances. My commentary, though, is really predicated on this. If you take the Social Vulnerability Index, that's 15 census tracts. The Social Determinants of Health in the 2015 defining paper commissioned by the AHA was 5 domains. If you take the Dispersed Communities Index, it's 7 domains. Arguably, there are more variables at the level of the community than 5, 7, or 15 that impact health. So my argument is that as we can better aggregate those factors, we can then be more specific in ascribing a risk of a community to a health consequence for an individual. We all know that in our given zip codes, there are people that have widely varied health and healthcare experiences. And so it is a crude convener, but it's still a convener, and it still has importance when we're trying to calibrate based on community. So my sense is that if we get to the next tier and not get too comfortable with the current model of SDOH, but get to the next tier where we're thinking about the social determinants, the structural determinants, which are largely policy issues, and then understanding how we can better assess risk and aggregate, then we might come up with something that helps us further diminish the contribution of race. And I love what you said as a proxy, because it is a proxy for something else. But part of that proxiness, if there is such a word, is the original comment. We have to account for the ever-present presence of structural bias in our systems. And that is hard to measure, meter, or otherwise incorporate. There's not a box you check for that. But it is one of those variables that allows us, if we can take everything outside of the equation, the small piece is genomics, this larger piece that is a community by various nomenclatures as we evolve that, there will be a residual piece. And I agree with you, we need to continue to incorporate race, particularly in epidemiological studies, so we can identify the new targets for exploration. But we will find that piece that still makes reference to the ever-present risk of bias.
So, as a follow-up question to your insightful comments, Dr. Yancy, it is tough to measure bias, right? And there are several scales out there that, for example, the everyday discrimination scale, et cetera. What are your thoughts about how we might measure bias?
You know, measuring bias is the way that we, sitting on this side of the table, are inclined to think. I would prefer to take an approach of acknowledging it as an ism. You can call it whatever ism you want. There are many that are proliferate in our society, and recognizing the necessity to educate, raise awareness, and remove this factor from the equation. I mean, trying to deal with it once it's there, it is exactly as you articulate. It is amorphous, it is unstructured, it's real, but it's hard to count it. But if we know that it is an ism, then we can think about a priori, what are the things we can do to remove that from the equation? And my one-word solution to that is, in fact, diversity. Having more people of varied, as you said, places where people live, work, congregate, play, and pray, allows us to change the dial, change our sensitivities. And so if we don't embed the bias to begin with, and I don't think that that's an impossible goal, then we don't have to worry about counting it.
Appreciate that. So, Dr. Coresh, you've been sitting patiently in the corner to continue along the concept around race. Certainly, in the United States, we have categories that we can fill out. Whenever we fill out an application, you may say, "Are you black?" or non-Hispanic black or white, etc. But certainly, there's also that multiracial category that also is part of this equation. Do you want to tell us your thoughts about how that may factor into research today and the equations?
Certainly, and we'll see how far I get, and if I can have the previous slide. So first of all, thank you on being part of this panel and having the opportunity to address this extremely important topic. I think when we developed the PREVENT equation, we tried to take the approach of being very inclusive. So in terms of place, we covered the entire United States with 6 million people. And this business of putting people in boxes, I think you're right, is highly flawed. It's a social construct with different labels and different biases that go along with them. So one thing we've done is, I think the approach has been the American Heart Association of focusing on modifiable risk factors and then looking at calibration across groups rather than anchoring at race being the thing. It's a thing to check that we've treated people as people and we have a goal of equity. And I think, as you said at the beginning, the goal of equity is incredibly important in implementing in the algorithms. And in some sense, what Dr. Yancy said, right, a lot of these risk factors like cholesterol and blood pressure are proximal and causal. A lot of the most powerful things like diet, exercise, policy, housing are not in the equation, but need to be addressed to get to the inequities in the measurable risk factors.
Thanks for that. And certainly, I would say that the person in the street who are not academics at major institutions should be factored into these discussions, because oftentimes we're having these discussions among ourselves. And when we talk about race not being part of these algorithms or not being part of a research, you may get a different perspective from someone who is trying to hail down a cab on the street, and that cab is not, stopping for them, and their impressions about why that cab might not be stopping for them. But nonetheless, we'll continue along with the discussion. So Dr. Yancy raised the issue about diversity in studies. And Dr. Coresh, you also just raised that as well. So what I want to do is I want to start with Dr. Powell-Wiley to ask each and every panelist as we go across, what are your thoughts about some pragmatic ways that we can increase diversity in studies? And what I want to do here as well is, oftentimes when we think about diversity in studies, we're often thinking about just patient diversity in study or participant diversity. And we're not often thinking about also the need for professionals to also be diverse who are doing those studies. So for example, a lot of the principal investigators that we're seeing presenting late-breaking science at our conferences are oftentimes not so diverse.
So this is a very important issue, and it really relates to who's getting access, who's represented in the treatments that we utilize for patients. And so we know that particularly as the United States becomes more diverse, the populations that represented in the United States are not being represented in clinical trials. And so there are methods that we can use to increase the diversity of clinical trials, but also to increase the diversity of teams who are doing the trials. So I'll start just from the work that we do. And sorry, I don't know if the mic sounds okay, but in terms of increasing the diversity for trials, community engagement is so critical. That's where you need to think about and work with community members and understand what their needs are and what are the barriers to participation before you actually implement the trial, and target those barriers as a part of the implementation of the trial. But more importantly, it also involves engaging participants and engaging communities throughout the process of implementing a trial, making sure that data gets back to the communities so that they know what was found, what we learned, and how the data that they provided actually can improve implementation and healthcare for future populations. And so these types of resources around community engagement related to working with community advisory boards, working with experts who live and work in communities, working with community organizations, that can start for any type of trial, not just for those that are community-based, but even trials related to therapeutics.
Thank you.
Excellent. Yeah, I think that's such a critical piece of how we want to move forward in advancing the science. If we think about clinical trials as our gold standard of evidence for which we apply in terms of developing and delivering the best care, well, we want to make sure that those populations are generalizable and represent the populations we want to treat and manage. And so I think one of the things that you mentioned was really, how do we improve diversity in clinical trials? And I think there's a science to that, and the American Heart Association has put forward a strategically focused research network to really start asking those questions. How do we ensure that we are recruiting a diverse sample of participants? Are they coming into clinics and getting care? So if we're doing a heart failure trial, are they being seen in heart failure clinics? And what is the makeup of the population that is being seen in a heart failure clinic versus a primary care clinic versus an FQHC? And where are these trials being conducted? So I think the location of where trials are being conducted is so critical. Who is on the research team? And are they representative of the patients who are trying to be enrolled? And so patients see who are part of the study team, and that diversity in the study team really can influence whether or not somebody may be interested in being part of a team. Are participants being supported? Is there compensation? Is there assistance for travel, childcare, elder care? And particularly thinking about the intersectionality of both underrepresentation of women as well as people of color in these trials. Well, oftentimes there's barriers when we're asking people to volunteer their time in being part of these trials. So I think there's a lot of different strategies, but we really need to think about how we can start to develop best practices and ensure that there are criteria for optimizing recruitment, and that perhaps there are penalties for not optimizing recruitment.
So let me take you in a different direction. Let's start with the macro answer to this question. Thinking about the data we all celebrated this morning, 4% of the patients in SELECT were identified as Black patients, 4%. Let's do the arithmetic. That means that fewer than 700 of 17,000 patients self-identified as Black. But let's do more arithmetic. This was across 41 countries. If we just make this simple, fewer than 20 self-identified patients as Black per country were in this trial. Is that sufficient to roll out a treatment that will retail for $1,000 a month? Do we have sufficient certainty that in that group, on average, with 20 Black patients per country enrolled, we know enough to, with certainty, say that this will work? So that sets the stage. But let me give you a very different perspective on this question, because what we're trying to address is, why do we see a varied expression of biology in different people? Not a varied biology, because I agree, race is not a biological model, it's a social construct, but we do see a different expression of that biology. I think the diversity that we need to also consider in the design of clinical trials, in addition to what Dr. Khan and Dr. Powell-Wiley have already identified, is a much more contemporary set of descriptors of the participants. Getting into epigenetics, getting into omics, understanding how we can gather many, many more data points than just sex and age and comorbidities. Right now, we probably get 7 to 8, maybe 10 or 12 data points about each enrolling in a trial. We have the science. Why can't we get the full array of omic information? Dr. Khan at our institution is one of the co-investigators for an initiative funded by the NIH, for which Dr. Sanjeev Shah is leading. Is the HeartShare project, collecting this extraordinary multi-omic data set so that we can have some precision about this variation in the expression of biology. That should become a standard, so that whomever we recruit, we can learn as much as possible, begin to know why people experience the disease differently, and can continue to mute the importance of race, except for that residual component I talked about before.
Dr. Coresh.
So, excellent points. And I don't have much voice, so I'll try and make 2 points briefly. I think number one, by connecting research with healthcare delivery and using delivery data for research and a learning healthcare system, I think we can both increase diversity and increase quality of care and monitor what we're doing. And I think we did some of that in the PREVENT equation. And I think the second point, I was talking with Benga Ogadegbe this morning, and I think many of you have championed this before, but I hope society will recognize that if we include diversity and equity, that is our road for excellence. And that is where our improvements need to happen. If we're going to improve lifespan, make improvements in cardiovascular disease, we need to look at the groups that are having the biggest burden of disease to make advances at the population level.
Absolutely, and thank you for those comments. And I actually think that we should probably bottle all of your comments into a perspective that gets published in the New England Journal of Medicine, because I think that these key points that were just raised here are some of the most consequential things about improving diversity in studies, and also the effectiveness ultimately of the medications and the therapies we develop for others. And I just want to remind the audience that when you look at population growth, in terms of the global population growth is most steep in the Asian diaspora and in the African diaspora. And these are two diasporas that are often completely almost excluded from clinical trials, as per Dr. Yancy's point about the SELECT study. Now, you brought up the point of epigenetics and omics, and I'm going to pose this question. I'm going to start with Dr. Coresh, since you're at the end of the line there and always having to figure out what to say after everybody else is done. So oftentimes, there's a lot to be said about precision medicine, right? Do you think our precision medicine efforts, as it relates to genetics, will help achieve health equity?
I think often the answer is not either or. So I love precision medicine. In our study, much like Sadiya's, right, we're testing the 11,000 protein assay by SomaLogic. We've got genetics, we've got epigenetics, we've got metabolomics, we've got it longitudinally. But what I tell students in my course and what I firmly believe is that for heart disease, we are all susceptible. And the AHAs, Life Simple 7 and 8, are true for all of us. So I think we are each unique, but we're also very similar as humans. And therefore, our biggest challenge is adopting the behaviors that we kind of know we should do, and then implementing the therapies that correct when we don't do the behaviors that we've done. And then the final mile will be our unique advantages and disadvantages and therapies, even though I would say that precision medicine will be potentially even more important to be precise to my personality rather than my epigenome.
And I think that's a really important point, connecting your comments and comments that Dr. Powell-Wiley made earlier. Look, there's a reason why lifestyle interventions don't have a high uptake, right? Because it is tough. I think one of our speakers said this morning on the SELECT trial. It's tough to actually count your nuts and count your vegetables, right? So we have to develop better ways to help us, the population, think about how we may individually adhere to lifestyle interventions. Dr. Yancy, precision medicine, genetics, health equity.
So this is an important question because it means that we necessarily must make every effort to not replicate the mistakes we've made before. Meaning, in the evolution of the randomized control trial paradigm, which became evident during my acculturation as a physician, because we omitted certain groups and the genesis of that information base, we spent decades trying to backfill or right correct whether or not beta blockers, ACE inhibitors had some utility in non-white populations because we didn't a priori engineer the design of the randomized controlled trial appropriately. The question on the table now is about genetics, and we're at risk for the same thing. My colleagues that do genomics tell me that the genetic architecture, that is the referent data sets necessary to do the important work, are inclined towards greater European representation. Because now when we're talking about genetics, we're no longer talking about black-white. We're talking about European, Indian, Asian, African. And so if we don't have enough of those ancestries represented, then we replicate the same mistake we made with randomized controlled trials. And oh, by the way, we're at risk for the same thing with data science. If we're using models, information platforms that are not sufficiently representative, some very sophisticated algorithms that meet the standard mathematically will fail the standard sociologically because by construct, they weren't inclusive. And so I think this is an issue. But I'm encouraged that the Million Veterans Study and all of me are intentionally recruiting populations that are closer to being representative than any data sets we had before. Dr. Khan has a lot of utility with our cohort studies and can speak to this. But we do know that some early data points coming from those two platforms are more representative than before, but not entirely so.
Yeah, and very important points, Dr. Yancy, because I think you're getting at the issue there. A lot of persons will say, let's talk about ancestry versus race. And the problem is that if you don't have the representation, then you're not going to have the distribution of the ancestry that you actually need in the studies. Dr. Khan.
So really great comments that have already been said. And I think one of the challenges that we continue to have as we think about health equity is the populations need to be diverse in the generation of evidence, but also in the dissemination of our clinical care. And so in my clinic, I do cardiovascular genetics, and a lot of times there's a barrier in terms of who is getting access to clinics for cardiovascular genetic testing. And so if there's less uptake of cardiovascular genetic testing in populations of color, then we're also less likely then to be able to have a precision medicine approach when we think about health equity. And that can be really dramatic for not just the patient in front of me who may not have been referred for genetic testing that needed it, but also their family members. And so this can have really far-reaching consequences from a health equity standpoint. So I think really important as we think about health equity and moving forward towards a more anti-racist approach to care, that the evidence generation, but also the dissemination for precision medicine be considered from that framework.
And so all of these points are very important and excellent. And I would just add, in terms of thinking about precision medicine, genetics, and health equity, that if we need to bring those patients into our clinics, if we need to have them participate in clinical trials or even clinical studies like all of us, or provide genomic data as a part of their workup, that engaging them in the communities, again, working with people where they are, educating them on what the importance of genetic data is, how that data will be utilized, really working to dispel the distrust that exists around utilization of genetic data. Those are things that we need to do if we're really going to bring more populations to the table and build work and cohorts that reflect the populations within the United States.
So thank you so much, Dr. Powell-Wiley. And we're about to close out this session, and what I've learned from you today is that, one, social determinants of health and social risk is an important potential predictor. But I think that with all predictors, it's a surrogate biomarker, right, essentially, for risk. And as we think about surrogate biomarkers for risk, whether we're using race, which is the old stuff to use, or social determinants of health, we really have to think about a few things. We have to think about the validity, right? We have to think about how it's quantified. And we also have to think about how it's utilized. So is it on that biological pathway, so to speak? And we covered a lot of discussion around that topic today. The other takeaway that I take from this session today is that you have to be nuanced and flexible, both in your research techniques, and also, we all know we are physicians on the panel, as it relates to your patient care. And lastly, you heard about PREVENT, which is AHA's categorization of CKM, which is going to become the new assessment tool for evaluating risk across a spectrum. I want to thank our panelists, Dr. Coresh, Dr. Yancy, Dr. Khan, and Dr. Powell-Wiley for being with us today. And I want to thank you, our audience, for your listening pleasure to us today. And feel free to come up and ask questions to any of us as we conclude. And obviously, I would like to thank the Doris Duke Foundation for the support of the ongoing work from the American Heart Association related to transforming how we take care of patients ultimately, because at the end of the day, it is about patients. Thank you.